So, good morning, everybody, and thank you so much for the introduction, Kathy. That was warm and appreciated. And to all the organizers, again, just a tremendous thanks. So, I'm going to talk about the MGH Myhre Syndrome Clinic. It began when I first met Kathy in 2014 till the present time, and there's currently 40 personally evaluated patients. I have a little asterisk because I have to tell you that as you'll learn, some of them were only evaluated virtually, and I'm going to be meeting them in the near future. For anybody who happens to be watching this later, please use your animation function. So just some disclosures, a little map of Boston where MGH is located that, I work with the foundation on the board. I'm on the editorial board of the American Journal. I also work as a clinical geneticist in the Department of Public Health. So the purpose of this talk in 45 minutes will be to tell you about the structure and staff of our clinic, a preliminary analysis of some genotype-phenotype differences. I know this interests everybody, comparing the different variants. A brief review of some of the defects and functional problems. Details will be provided by others. So you'll hear from Mark Lindsay, Bernie Canane, Michael Cohen, my wonderful colleagues, and talk about some clinical research studies and collaborations, and of course, future directions. So just a quick review. I've shown this before of my wonderful team. I can't thank them enough. They're so generous. It's multi-specialty. We cover pediatrics to adults, 40 patients from 1 to 50 years. We now have a wonderful clinical research assistant. Thank you to donors and to the Myhre Syndrome Foundation. On the wish list, I would love to have a coordinator and a genetic counselor in the future. Let me just talk to you about some of the tools that I think are important. A website, handouts. I created something called a passport to the emergency department. I try to give little gifts when my patients visit me. I do have a standardized intake form for my exam and for the way that I present my results. We have a handout to tell people how to take photos during this time of virtual medicine, but it's really a wonderful way to prepare. As you know, my patients will know you get a very standardized form. I will summarize for the most part the other specialists. Most of the specialists do not send out reports to people other than the referring PCP. And patients who participate at MGH can view these records now through Epic, through their portal. But I still try to summarize it, and my little diagram there. So again, to recognize that we are not the only people of expertise who can see patients with Myhre syndrome. We are probably the only clinic and the one that is coordinated for all age, but these are all the different places around the country, around the world, Canada, Europe, and Australasia. So thank you to everybody who's helped, getting to know this syndrome. So I've shown this before that we have a model of care PCP with me as sort of the director, our most common consultants, as well as just about everything. I really think we have everything covered. So I'm sort of like a navigator helping people. And I have this little diagram to say that really what wraps us around is a particular EMR. It's called Epic. I'm not endorsing it. I'm just naming this as this is what we use. And it has this cool tool which allows us to see elsewhere to other Epic using centers. This is invaluable. It's called Care Everywhere. And otherwise, I need to have patients send us their report. So I think validation of self-reporting symptoms is key to any good research. So I've acknowledged before the importance of having patients who share their stories. It teaches me. It's sort of a two-way teaching tool, and thank you. I've also mentioned in another talk that I think of care across the lifespan from prenatal, which is only theoretical right now, through the school years and up to adults and the most senior. And for each of these age groups, there will certainly be a type of a core of different issues that we'll be thinking about. And as people get older, we sort of customize it for their age group. And this is more reflected in my other talk, the keynote talk. So here's the way to begin. How do we pronounce this name? So this is Norwegian. And when I've talked to my Scandinavian friends, they've said it's pronounced Myhre or Myhre. In the United Kingdom, I've listened to people pronounce it Myhre. And in the United States, where Dr. Myhre lived in Washington State, and I found a veterinarian in New Hampshire, it's Myhre. So for convenience, we're going to use that. And I apologize to my Scandinavian listeners who may feel I'm incorrect. A key thing is to begin with prevalence. And, Bert Kyra did it beautifully in his talk. And I'm just going to cheat and repeat some of his figures. Using a database search, Nomad, which was very clever, the estimate would be, I think it was 3 variants, so it was a frequency of about 1 per 40,000. In the literature, there are at least 100, but that's certainly a minimum count. They're growing, mostly just case reports or small case series. But I think that's going to grow in the next year. In the United States, if I estimate 5 to 8% per state. That's just a guesstimate. We might think that there might be 250 to 300 or 400, and that's about 1 out of a million. These are all guesstimates. Worldwide, I'm going to say rare, but it's likely more common. So in summary, the prevalence could be as uncommon as 1 out of a million to as common as 1 per 50,000. And of course, I think one of my great interests as others is talking about the genotypes and the phenotypes. So Myhre syndrome conveniently has genetic homogeneity. It is only, I feel it's a tautology. SMAD4 gain of function defines Myhre syndrome, and Myhre syndrome requires that for the diagnosis. So it's recurrent, pathogenic variants. There is phenotypic heterogeneity, tremendous spectrum, and almost every organ system is involved. But not all patients have every feature. Some patients seem to have most. And this is really an age-related phenomenon. That's why when I show you my data, we have to keep in mind that I wasn't able to stratify for, say, young children, middle years, and the most senior. So things progress over time. This cycle or circle I'm going to show you will sort of echo something that Valerie had shown. If we start with the original description, it's been greatly expanded. So this is the Dr. Myhre's report, as well as a series of important reports by Norlane Linder. And the working definition, I think, first appeared by Valerie's group in Le Goff in the gene discovery paper, where she listed things like stature, brachydactyly, dysmorphic face, the skin, the muscles, hearing loss, the delays, heart, cryptorchidism, bone anomalies. And that was echoed by the Caputo group, who also reported the gene. Their description was more sort of iterative. Clinical features fitting Myhre syndrome were included. But it's important to actually list them to grapple with what exactly are we talking about. So Lois, Norlane, and I, we sort of imitated what the Le Goff group had reported when we wrote our gene reviews. And we said the criteria have not been published, but we call these suggestive findings. And then Lois made a valiant effort to try to come up with criteria. What are the minimal diagnostic criteria? And out of this common group, at least 5 out of 7 would probably make the diagnosis. We tried to continue it, but we got sidetracked. So for more details about the genetic basis, go back to yesterday's talks and listen to Lois's wonderful discussion. It's suitable for families and providers. I loved it. So to talk about the MGH experience, this will be a tease when I show you my data. Each slide could be a research study about a specific topic. This talk is an overview. Details are forthcoming for a publication. This is the spreadsheet that I work with. Imagine one column for each patient and probably about 200 rows. With more experience, I add more variables. So unlike the best epidemiology research that I've worked in, where you really start out with your metrics, your criteria, your goals, and you don't deviate from them. I think clinical research, clinical data collection is a little bit more flexible. And so here I am sowing seeds, and I think some of them have already taken root and others will be inspired. So the strength of my data varies. I would like to think that the MGH evaluations are the most rigorous. I do try to collect outside, testing and consults, et cetera, but these records are often incomplete. They're only as good as my colleagues will send them to me. In this pandemic, we have had video exams, which have been very successful for doing a modified physical exam. Photos really supplement it. Parental self-reporting can be extremely helpful, but it is unvalidated. And what is really incomplete is sort of the variation with younger age, with autism, and during the pandemic. I have not been able to do multivariable analyses and statistical comparisons for obvious reasons. This is sort of just a univariate, actually probably bivariate analysis. And all my percentages are rounded because I don't think I have the rigor to report more. So I'm going to compare some of the findings with what we reported in 2016 in our cardiovascular paper. I'm just giving you a little screen grab here. And I think that's useful because I'm trying to make the claim that if a person or a group sees patients personally using a very standardized approach, the data should be more reliable. I'm not saying it is, but this is what the hypothesis is. In our first paper, we had 54 patients, which is a large number, and it included generously the patients from Michaud and Valerie, as well as 4 new patients. And I want to sort of echo again something that Valerie said. When I think of research, I think of number one, what I'm doing now, good old fashioned clinical description, or in a fancier expression, deep phenotyping. So we talk about defects, the things that are congenital, anomalies, malformations, but also the functional problems. The first are a little bit easier. They're objective, yes, no, got to find them. Functional problems are much more difficult to record. And we want to know who has what, when, and where. And the next stage is sort of the really fun stuff. And this was what is going on already, pathophysiology in humans with animal models, hypotheses that are current and proposed, why and how. And of course, we're interested in developing research that leads to therapy, symptomatic, translated from genetic defects, and then trials both in animals and in humans. So I'm going to start out with what I call descriptive epidemiology. And at the top of every slide will be this similar data report. It'll compare, when possible, what we saw in our 2016 paper to what is the total. And then I will sort of do some gentle genotype comparisons. I'll have the SMAD4 isoleucine 500 variant comparing to the arginine 496 one. So to start out with, total number of patients is 40. 25, or almost 2/3, have the isoleucine 500 variant, and a little more than a third. This is a big deal. This is a lot more than when we reported 2016 when there were only 6%. And that's really because of earlier diagnosis. That's bringing it up. So I just want to mention this is the distribution of the specific variants. So the most common one is that isoleucine changes to valine, at least half. Threonine, the change to threonine is rare. I had no patients with methionine, but this is exciting. Just within this 48 hours, Bert and I have a hypothesis. In his study, I don't know if you remember, he reported that his adults, the predominant variant was the valine to, the isoleucine to methionine change. That's a remarkable comparison. So not subject to statistical comparison, just quick comparison. And I just mentioned that we do have a patient who has a novel variant. It changes from isoleucine to leucine. So most of our patients are in the United States, but 12% are outside. About half are self-referred, half come from a doctor. And 7 patients, 18%, were evaluated only as telemedicine, but everybody is supposed to be coming back to see us in this current year. And I'm happy to say that most of our patients have been evaluated more than once. So the age at diagnosis is getting much younger. I didn't even have data back in 2016. So 18%, almost 20% are less than or equal to 2. And I think that's really important. And a trend analysis over time would show us that this is going to be growing. Adults, again, almost 20% that we follow, and I'm just so pleased to have that information. Most of our patients are white. We have a rich diversity of patients who are Hispanic, Portuguese, multi-ethnic. We do not have any patients who are Black. And if people know of any families that are Black, I'm very interested because I hope we are not missing them. And in terms of the sex breakdown, we have a little bit of a shift. It used to be nearly identical to 50-50. And what you can see is it's still about 50-50. I wanted to see if there was a difference between the variants. And there does seem to be one slight difference. Of patients, of the males with Myhre syndrome, more of them are likely to have the isoleucine 500 variant. I'm not sure why, but that's a little bit more common. So let's talk a little bit about genetics. I think you'll find this interesting. So not surprising, the most common test is whole exome sequencing, but look at the leap from 6% to 82%. And some patients get picked up by intellectual disability autism panels. We like those. cancer panels. Isn't that interesting? A patient can be identified because somebody was screening for cancer and they found the SMAD4 as the gain of function. Targeted gene is uncommon. I've only done this once myself, but it's interesting. They were always the isoleucine 500 variants. So I have some information that I think is new. In our series, we have parents who've had infertility for a variety of reasons. An inherited Robertsonian translocation, MTHFR variant, sperm issues not specified, but the frequency 18% is really pretty close to the general population. So I don't think that's different. I've been very interested in advanced paternal age, which was first reported, and there are years where I think we see it, there are years when we don't. So here's our data. At first glance, I would say that we do have advanced paternal age, and I'm defining it by over 40 years. Some people say 45. So this is 30 versus 10% in the general population. And the mean maternal age, I didn't calculate a median, is greater than what the population says, so 37. But as one of my colleagues said, what about the mothers? I had not even done that until now. And this is very interesting. We have older mothers defined by older than 35. So 45 versus 5%. And this might reflect really a societal, socio-cultural change towards later parenthood. The maternal age of 32.7 is greater than the population. So this will take some interesting discussion later on. And for my colleagues, we know that advanced maternal age is well known to be associated with single mutant genes. The most common one is achondroplasia, Apert syndrome, and several others. But to parents who might be listening, even if there is an increased risk, even if a parent is a father is older, it doesn't mean causation. But what we're doing is looking for risk factors. So let me tell you a little bit more about some genetic features. It was interesting that when using exome sequencing, 25% had a variant. That's 10 patients. One patient had a variant that turned out to be familial. We thought that variant was probably not pathogenic. But 3 patients, interestingly, had variants that were pathogenic. We would use the expression of dual diagnosis. So one child, for example, has a co-occurring ichthyosis. I also looked at twins, and I think this is interesting, and I hope people will help me research this in the future. We had 5 twin ships, always dizygotic, and the female was usually the proband. 12% versus the general population of 1%. You might wonder, could this reflect the advanced paternal age? Definitely, possibly. So let me switch to the heart and let you know that this is only a preview. Mark will follow. So the risk of having any cardiovascular abnormality is about the same, about 60%, so we'll say 2/3. A structural cardiac defect, a congenital heart defect, about 1/3. And as Mark had mentioned in yesterday's talk, if you heard him, we see sort of benign ASD, VSDs. PDAs do tend to be larger. So they can be little skinny strings like we see in low Ds, but 2 of them have been quite large. In this particular series, I did not see right-sided defects, but I know they've been reported. We did see patients who had aortic and or mitral valve dysplasia. And I think somebody also had tricuspid valve involvement. And we can use the expression polyvalvular dysplasia. And interestingly, one patient who has tetralogy of flow, who will be part of a series which is in development. Other things, pericardial effusions, which are usually not an innocent transudate. They're usually either recurrent transudates or they're more exudative. It's pericarditis, thick stuff, about 10%. Restrictive cardiomyopathy remains rare. We have one patient who has this clearly as a diagnosis, and there's one patient who now carries this with an additional problem. I won't say the diagnosis. I don't want to reveal the patient's identity, but we realize that the cardiac dysfunction, probably more of a diastolic dysfunction, may be more common. And this is an area for research in the future. So this is the question mark. Mark and I are very interested in this. And several patients, 6, which is about 40%, have had echo reports, which mention at the bottom LV trabeculations, strands. At first, I didn't even record them. But when I realized how common it was, I think it's something to follow. These might be very innocent atavisms, a remnant of development. Does it signal a prodrome for myocardial dysfunction? So far, no signs of that. These do not meet the criteria for non-compaction. And Mark's talk will follow. So a little bit about the aorta as opposed to the structural defects, okay? So there's no patient that has a classic dilated aorta as in an aortopathy. You're going to hear me talk about the vasculopathy of Myhre, but we don't have an aortopathy. One patient does have an enlarged aorta, but this was following arch surgery. I don't know if this will progress, but we're marking this. So classic coarctation, let me start again. Coarctation was noted in 3 of our patients, which is 8%. One is a classic ledge, juxtaductal. 2 are long segment. And after somebody asked yesterday, what about recoarctation? In 2 out of 3, there was recoarctation. These were the patients who had who had the long segment. So that is a concern. Hypoplasia of the aorta, whether it's the arch, the ascending aorta, the transverse arch, the descending, is to me is to us the most common phenotype. So we see it in about 68%. This could go higher depending on how we do the calculations. And in fact, if you use as the denominator, not all patients 40, but 37 who were imaged, it's 72%. So what about imaging? Echocardiography was performed at MGH in most of them. And we do feel it's very important that we do our own echo. Excuse me. But and in another 18%, it's pending. So these are the patients who are coming to us. In one patient, it was done at a related partner's hospital. What about cath? Oh, this was done in 5 patients, 12%. Those were the ones who were thought to have either a congenital heart defect, a severe one, or somebody who may have had cardiac dysfunction. And additional imaging really is a part of our playbook. So we do usually a CTA without anesthesia. It's a tribute to our wonderful child life who accompany the child and the family, distract them. So we don't need to use anesthesia. There have been people who've had an MRA, and some have had both. It's about 2/3. Ideally, we would like to feel this would be nearly complete in all of our patients, but we don't do it if they're too young or if there is some other concern. And 5 patients have had surgery, 1 for the coarc, 3 for the coarc, 1 for tetralogy, and another patient who needed a pericardial window cut for the pericarditis. What about hypertension? In any population, very difficult to count, isn't it? So let's say it's at least 60%. There's something that I always pay attention to, which is called the pulse pressure, the difference between the systolic and the diastolic. It's more of an interpretive feature, and I didn't show you any data. What about pulmonary hypertension? Very important, possibly underestimated, certainly in at least the 2 patients who had the restrictive cardiomyopathy physiology. And what about medications? Well, there's a whole array. At least 4 have had this group, the losartans, the irbesartan, which is more popular from non-US families, calcium channel blockers, beta blockers. So what about other arterial systems? And I must credit my colleagues. So when I tell you about renal imaging, thanks to Alana Paul, our nephrologist. And so 90% of our patients have had their kidneys looked at in some ways. It might have been an ultrasound. In 86%, there was something with dye, either an MRI or angiography. There is narrowing in 8%, hypoplasia in at least 1. Renal artery duplication, which was in 10%, but it turns out that that's really not a high frequency. And a view of the brain, the cerebral and cervical circulation, thanks to Paul Caruso, Karen Book, my colleagues. And so 45% of our patients have had an MRI at least. We often wonder if this should now be part of the playbook. Should this be part of the surveillance? And this is probably the most interesting finding. Now, we're talking now not about the vessels, but about the cortex. 22% have had what are called variously white matter abnormalities, hyperintensities. And to my colleagues out there, you can go back and look over some of your data. And in the beginning, I was very sloppy about recording this because it would be read as old infection, old ischemia, until I realized how common it was. So we are identifying that they are present. We don't have a consistent pattern or an association with other things. And this, in fact, is a project we're going to be starting in September under the research assistance lead. So this is something that you do need to know about. In addition to the hypoplasia elsewhere, at least 4 patients have had hypoplasia in the internal carotid arteries. And the only thing that stopped us from imaging more is that it would take an MRA of the brain, and we haven't added that in consistently. But I think we need to pay attention to that. And CTA has also picked this up. Finally, a salute to Chris Learn, who is our adult CHD specialist. And he looked at every patient to see if there was any comment about the coronary arteries. One patient had an innocent anomalous, well, it's worth noting, an anomalous right coronary artery from the sinus of Valsalva, and 2 patients had coronary artery disease, 2 adults. They also had co-occurring issues such as diabetes, lipid, overweight. So we're not sure if it's multifactorial, but in fact, in one patient, it made the grade to call it severe stenosis and another moderate. So this will be part of the research project that's being led by Tim Van Dam and Bert. And I just want to say to the dysmorphologists out there, I think of the heart as a phenotype. It speaks to me. We know the familiar ones: Down syndrome, trisomy 8, the rasopathies, Williams-Billings syndrome, Marfan, Loeys-Dietz, and DeGeorge. And to this list, I think it's really fair to add Myhre syndrome. The things I've described, they may not be unique, but as a pattern, they really are recognizable. And that's the point. We want people to be able to recognize them so we can prevent, say, severe pericardial disease. So I'm going to switch gears, talk about the airway, but again, this is a teaser for Bernie's talk. So stridor croup, it's kind of a difficult sign to pick up, at least 30% of our patients, 32% reported it. I think this is very important. Choanal stenosis progressing to atresia. This is a sign of what is going on in the proliferative part of airway disease. So Mark and I, as he mentioned yesterday, and I will today, I really think about these different issues as congenital or progressive. My feeling about the airway, as I'm going to tell you, is I realize that parents are in fear of intubation. But as several parents have said, Dr. Lynn, my patients have had 10 or 20 intubations. So I have not seen in our series any patient who has developed this because of intubation. In fact, what I'm paying attention to are the congenital or progressive. So example, a person might start out with choanal stenosis, but progress to atresia. We've seen it once, and there's a new patient in literature coming out. This is concerning. There are these congenital, or let's say developmental abnormalities: mild subglottic stenosis, vocal cord nodules, which actually might be progressive, a retroflexed epiglottis, which may be non-disease causing. But I'm looking for these things that people are born with. We do not do imaging of the airway at present time. We've been just thinking about this. And this is really the most severe pattern: multiple choanal, tracheal, bronchial stenosis. This is a patient who's being treated with now every 1 to 2 weeks ballooning of the airways. This can lead to fatalities in the literature. And so if you take all these different possible anomalies, it's really about maybe 10% will have them. Abnormal sleep, common, at least over half. Hard to ascertain from just reporting. You need to do a sleep study. So I don't know if my data agrees with Bernie. I think we've seen this in about 25% that have had a sleep study. And it was normal in 3 out of the 11. So it was performed in 11, and then it was normal in 3. In terms of the drugs that have been used to treat this, so many, and it was really too hard to enumerate. And again, more about what Bernie will tell us about Dr. Kanan. Evaluated by Dr. Kanan, 70%. If I say among those eligible, 88%. So who wasn't eligible? Virtual visits, patients who were just not available for study, even the youngest patients he's seen. So I'm going to say it's 88%. I'm not sure if we've missed any. But a few have been evaluated by colleagues in town, the Brigham, Beth Israel. In 2 patients, it was not done. And several, as I said, they're just too young, will follow up. Frequent colds, about a third. It's a tough variable to collect. So this, I think, is important. I would say about 25% have reported, quote, asthma. And asthma means a lot of different things to different specialists, providers, and patients. But from my review, only 1 out of 10 had a response to bronchodilator, which in some ways is sort of a definition. But again, this is Bernie's expertise. He'll tell you more. So pulmonary function test, about among those eligible, 73%. So that's a great effort. Sometimes the effort is made, but the cooperation is not possible. A view of the lungs by CT and pulmonary function test, 28%. Okay. The assignment of a classification is really in the hands of Dr. Kanan, but we are focused on what's called restrictive. In some ways, part of it is simplistic, the stiff chest wall, the hypotonia, what parents can see themselves, what they can report to me. And of course, we integrate the pulmonary function test. So about maybe three-quarters, the majority will have some form of restriction. Interstitial lung disease has been reported in the literature, which is the asterisk, and we know of 2 patients that will be coming out in the near future. So it is there, and Dr. Kanan will discuss this further. And this is his talk. Thank you, Bernie. So what about the face? I'm talking about the face both in terms of facial features. I feel the facial features are nearly 100%. Of course, I have I have a biased view when I look at people, but some other craniofacial features. Macrocephaly, what I call relative macrocephaly in the majority. In other words, there is some, um, if the growth or the height is less than the 5th centile, the head circumference might be 20 or 30th percentile. That is not a formal definition of macrocephaly. It's not megalencephaly, but I call it relative. Cleft lip and palate, 1 patient, submucous cleft, 1 possible, and VPI. So VPI we should discuss. So velopharyngeal insufficiency, and I'm using a broad definition to include patients that I see in clinic who have articulation problems and hypernasal speech, and VPI is something that I think is present. I think the reason for it, the hypothesis, is that the palate is probably a little shorter, stiffer, less mobile, so you don't close off the posterior nasal pharynx. Some patients have more than the usual facial appearance, and they might have what I'll call prognathism. So that's about 15%. And this is an area I think of very important research, which is restrictive mouth and jaw opening. In at least 1 patient, it is severe, but I think there are probably more if we study them systematically. Small teeth seem to be present in about 45%. This is very subjective. Extra teeth in 5%. And a 7th cranial nerve palsy in 1 of our patients. There are several others in literature that we saw during the slideshows recently. So switching to ENT hearing, and Dr. Cohen had prepared his talk. Recurrent otitis media, at least half. It kind of depends on the definition of recurrent. Tubes in about half. And I think this is one of my favorite Myhre syndrome features. Unusual earwax. It's not even earwax often. It is copious material. It represents desquamation usually. And as Mike and I said, we need to get a pathologic examination of that. So again, I'm sort of screening, I'm presenting the initial data. Hearing loss, I had initially reported 83%. In this current series, it's defined as 17 out of 40, which is 42%. If you define it by those who had an audiogram, it's more like 50%. So at least half. And this is definitely age related. So I think that I have a feeling that this number 80% is more correct than about half. I think it depends on how closely you test people and whether you follow them over time. And a lot of families I notice will rely on subjective. They'll say, I know he can hear me. I'm sure he can hear me, but that is really not enough. You need to have a formal test. But this is something that echoes what Mike said. Sensory neural isolated is very rare. It's usually conductive or mixed, but rare isolated sensory neural is uncommon. And I recorded the number who are said to be using hearing aids, but whether they actually use them is, variable. So that takes a little more analysis. Inner ear anomalies, 15%. So to my geneticist colleagues out there, you can think of the syndromes like CHARGE, BOF, BOR, probably some others that have inner ear anomalies. And I think Myhre syndrome will probably join that group now, so 15%. And this will be Mike's talk. It was pre-recorded. It's an excellent talk. So what about the eyes and vision? So it's interesting. There is sort of a most distinctive pattern of acuity, and it's hyperopic astigmatism. We have seen some patients of myopia and some who don't have astigmatism, but this is most distinctive, so 40%. And why? I don't know if it reflects the shape of the lens. I'll need other people to help me out. Strabismus, esotropia, I lump them together, about 20%. Nasolacrimal duct stenosis, I find this very interesting because I do think it reflects sort of the proliferative process. It could be that this is sort of a congenital anomaly, nasolacrimal duct stenosis or atresia, but there are a lot of patients in whom it is undiagnosed. They will tell me their children either don't cry or they have, the tears are coming out of their nose. So I wonder if there is stenosis. So this is also something interesting, what I call pseudopapilledema. And it began innocently as just one patient. Now we're up to 6, and this is 15%. In the back of the eye, the optic cup and the optic nerve does resemble what you see in papilledema. This will often trigger a neurologic emergency, a referral to the emergency room, a referral for an emergent MRI. And in at least 2, there may be 3 patients, the brain MRI was done for this reason to exclude pathology, and it's not there. So here's a thought. You guys can tell me if you agree. I think what we are seeing is a change in the shape and the pattern of the optic nerve. I think it may be related to the direct gene action, the activating. Sometimes this appearance is also called a drusen. So sometimes the ophthalmologist will say, papilledema, drusen. And so what we're talking about is appearance, but there is not the physiology that corresponds to something in the brain. And some miscellaneous defects. And the one I want to tell you about is congenital meiosis bright green irides. It wasn't until recently that I realized this had some significance. This child's eye finding will be part of the study coming up on tetralogy of Fallot and neural crest lesions. And this is under the direction of Nicola and his colleague Gerardo Capuccio, really hardworking. I do feel this is consistent. Green irides, I had to look this up. It turns out that this is as distinctive as bright blue eyes, which we can see, say, in Noonan syndrome, and it does reflect sort of neural crest development of the irises. So some brain imaging basic comments. So a brain MRI in about a third of those who, I'm not sure why I have the denominator is 25. Oh, I know. It was abnormal it was done in 13 and then it was abnormal in 13 out of 25. And what we saw are fairly benign anomalies, and they're all over the brain. So unlike some of our genetic disorders where you have forebrain, hindbrain, we had a dysmorphic corpus callosum. I think there may have been 1, maybe 2. One person had a true developmental defect, Chiari malformation. 1 small pituitary, 1 turned up really a bone abnormality, dehiscence of the temporal bone. And in my cancer talk, I mentioned that there are 2 patients who have idiopathic hypothalamic hyperhamartomas, which, as you know, are deep in the brain. So that's the midbrain. They are not structural abnormalities, but they do count, I think, as something that's developmental. And again, I'm mentioning this issue about the hyperintensities, the bright spots. Clinical seizures, tough. I think at least 1 patient may have had them, possibly 2. Abnormal, suspicious EEG, maybe 1. I don't think this is part of Myhre syndrome in general, but I think that it has been observed. So a little bit about some other features related to neurology, neurosurgery. I think I mentioned the idea about the relatively larger head. Sacral dimples in about 40%. We're going to check that data. As you know, dimples can have many different sizes, depths, position. None of them have been the type of dimples that we see in neural tube defects. They are not high up. They are not off center. They are not associated with overlying cutaneous markers such as capillary hemangiomas or hair tufts, etc. And none of them have really led anywhere. They're all blind ending. But many of them are quite deep, and they have prompted an investigation of the spinal cord, especially in the setting of something else. And the something else might be the possibility of a neurogenic bladder or a neurogenic bowel. So we try to think of these as a cluster. 1 patient has had a vertebral CT, and it's the spine is something we need to be thinking about in the future, not just the lower, but the upper. So 4 of our patients had detethering. None of the patients had a severe, tight, bound down lower spine. In all of them, there was a cluster of symptomatology, low-lying conus, sacralization of the vertebrae, and maybe a suggestion of some other pathology. And so that's 4 out of 40 or 4 out of the 13 who were actually imaged, so about a third. Outcome is really too soon. This has only been in about 1 year, and I don't think I can report on that yet. But again, we need to pay attention that the cervical sign does become abnormal in later life. We don't know how many of these patients start out as congenital anomalies, but later in life there can be spondylosis. They need disc surgery. So neuropsychology. So I have found that neuropsych testing was done at MGH any type of testing was done in about 22 of our patients. That's about 55%, about half. 11 of them were done at MGH. It's possible that Amy Morgan, I apologize for forgetting her, that she may have had more in her data set. And then there have been others that were done elsewhere. A lot of them sort of are in the queue, either because they were virtual patients, because of age. Neuropsych testing is not easy to get, even at MGH, where I have wonderful colleagues, wonderful resources around the country. There's a wait of at least 6 to 8 months. So what about the brain function? And this is rough data subject to disagreement. In my experience, I do feel that all of my patients have had developmental delay, some delay at growth in early development, in academics, or supported through school with SPED or special programs. I have not met anybody who has sailed through life or through academics. I don't know if there are any patients out there who would disagree with me, but in my experience, this is true. So what about intellectual disability? So there are different ways of defining it. So if we use an IQ less than 60, which is very coarse, I would say that 14, maybe 1/3 have intellectual disability. What about patients who are borderline? Either because they have a testing that says, borderline around 70. And the report will say that. So if you add in that, that's 19 out of 40, and that's about 48%. I think that intellectual disability cannot be enumerated by self-reporting. And studies that have come out that cite a much lower frequency really surprise me. I think we need to do the testing. So what about executive function, dysfunction, ADHD? So at least 60%, it may be higher. The medications that are used, they're variable, and they need to be looked at because some will cause an exacerbation of hypertension. What about autism, the spectrum of autism function? What about the milder end, which are called social challenges? So in our experience, I would say 33 out of the 40, 80%, the majority are in some way on the spectrum. And I've been fascinated, delighted to hear some of my older patients say, as a child, Dr. Lynn, I clearly was more on the spectrum. Right now, I have an insight into my life. And I think that's really very inspiring. There are patients who I feel are not said to have autism, but they have social challenges, and I would probably include them, but we wait for additional testing. So a formal psychiatric diagnosis was reported in 5: depression, anxiety, outbursts. Now, what do outbursts mean? Are they really psychiatric? I don't know. These might be children who just have severe autism who have not been well managed. In our series, we do not have anybody with psychosis. There is at least one patient, maybe two, out there who have this, and I do respect this as a possibility, something we should be thinking about for the future. Let's switch gears, talk a little bit about endocrine, hormones, growth. So this, I think, is one of the few examples of a genotype-phenotype difference. And I've talked to Valerie, and I think she agrees. So some form of growth retardation, whether it's SGA or IUGR, is present in about 65%, 2/3. But this is by no means ubiquitous. So when you separate them out based on the variant, of patients who have the isoleucine to 500 variant, most of them will have a small size. When you talk about those who have the arginine variant, only about a third. Now, I don't know if the numbers are large enough to do a statistical comparison, but I know that if I hear about a patient who has Myhre syndrome, who's tall, who maybe doesn't have a severe heart defect, and that's variable, I usually will guess, I'll say, does this child have the arginine variant? And it usually does track that way, but more research needed. So what about what about the use of growth hormone? We currently do not endorse it. That is a discussion beyond this talk, but it has been used by 4 people who were prescribed on the outside. In no patient was it long-term. In no patient did it show consistent improvement. That's about 10%. The bone age is advanced in about 20%. And I guess I should just say the reason we do not endorse it is number one, we feel that this is a drug that has the potential theoretically to exacerbate the intrinsic pathophysiology of the SMAD4 overactivation. And we don't know if this could exacerbate some of the processes, such as the proliferation. Number two, there's also an interaction, if you go out far enough, between TGF beta signaling and the IGF pathway. And we don't know enough to know if they could interact in a positive way. So what about puberty? So premature puberty occurs in males, about 24%, slightly more in females, in about a third. And I tried to separate out whether this is more common in the women with the arginine 496 variant. A little bit more, 27% versus 16. We'll need larger numbers to separate that out. One patient now with premature ovarian failure, so maybe early menopause, diabetes in 12%, overweight in at least 18%, probably more. This is age related. And folks, this cluster is clearly something that the adult study group will be looking at. What about GI? So in terms of congenital defects, duodenal atresia in one of our patients, reflux in 12%, maybe more, a G-tube in 3. I think this is really a clear signal that some patients have enough of a feeding disorder that they need help. Overeating, we've seen in 2 patients now. So this is more work for our internal medicine colleagues. There are a lot of metabolism features. These patients remind me of some of my patients with Turner syndrome when they're older. So liver dysfunction, non-alcoholic liver disease, elevated liver function, gallbladder stones or sludge. There are 2 patients, one patient who has classic protein losing enteropathy. And we think that this dysregulation of protein albumin production is probably more related to what is related, which is you have a cardiovascular circulation. So what's going on in the heart reflects what happens in the liver here. So GI, constipation, technically I abstracted, 50%, but I think it's more common. Alternating with diarrhea. So when I hear diarrhea, I generally think of this as a pattern. I generally think of this as sort of the escape stool coming around, but I can't assume that. And how many of them persist despite vigorous clean out? This is such a issue in progress. I couldn't really calculate it. We are interested in the role of anal manometry because we are interested in whether the constipation is not about fiber or fluid, but is it about the intestine? Is there peristalsis dysregulation, in particular in the distal bowel? Colonoscopy, endoscopy was done at least once. And I know there's a tendency not to want to image the intestine, but folks, I think this is the future. We need to do a better job of not just treating the symptom, but really looking at it. When possible, we might need some biopsies. So quick things about musculoskeletal. Let me watch our time. Okay. Stiff joints, most patients, more severe contractures at about 15%. And I think we have an insight here. I don't think this is arthritis, as we see in rheumatoid arthritis or osteoarthritis. I don't think this is a destructive process. And the reason we know is there's at least one patient who's had 2 MRI scans, which is aggressive. And it showed in one that we thought maybe there was a destructive process, but in the second one, completely non-destructive. Our theory now is that this is actually external. In other words, the severe skin stiffness, the severe fascial collagen abnormality. So put this together, I think these patients might be more like those with some forms of scleroderma or stiff skin syndrome. And I hope Nicola will address that later on. Short fingers, very common, clinodactyly, camptodactyly. Short toes are less common than short fingers. There's this quirky little anomaly shown up here, syndactyly of toes 2 and 3. And geneticists will think of Smith-Only-Open syndrome when you hear this. And we see this here too, a lot of overlapping toes. Scoliosis in at least 10%. This is something to be studied. Fractures in 15%. I was not recognizing how common they were till I really sat down and tallied them up. They are in the long bones, tibia, femur, radius, and we need to work with an orthopedic surgeon to review them. They're usually associated with some sort of innocent trauma. This is, I think, a very useful feature. I hope clinicians will look for this. Reduce pronation supination. I know that when I scan for the joints, I tend to do flexion extension, but you need to do the rotation of the lower arm. So some radiographic findings, I myself do not do a skeletal survey in everybody, but it has been done in 18%. Wormian bones, just a developmental anomaly. Thick calvarian in 3. Again, I'm not doing this skeletal survey in everybody. 11 ribs, kind of an interesting developmental defect, and 13 ribs in at least 1. Sacralization is something we should pay attention to. It means what is going on with the vertebrae at the bottom of the spine, but we also should be looking at the top. And I regret I do not have the data for our skin findings, which is a shame because I work with some wonderful dermatologists. And what I can show you is that we feel that thickened skin is present in almost everybody. Some parents will surprise me, or I will say, I don't really feel it, but most. Hyperkeratosis pilaris is not distinctive, unique for Myhre syndrome, but very common. And it's this bumpy little, parents call it chicken skin. I seem to find it more on the upper extremity, the shoulders, the back. Hypertrophic scars, classic keloid. So here's a hypertrophic scar, but a classic keloid like you might see in Turner syndrome, definitely been seen. And at the site of, say, surgery or something else. Persistent scars. The parents clued me into this. Most patients have these very interesting little scars. They're linear, they're white. They're not hyperpigmented and nor are they hypertrophic, but they seem to represent some type of dysregulated scarring. And one patient really had true poor wound healing, which I think might be the difference, might be location, relation to surgery, and possibly tension. So I know another patient who had one, this is in regards to spinal surgery. That's something we need to be thinking about. Several patients seem to have hyperpigmentation. A few have cafe-au-lait macules. And I regret that I did not record the exact numbers. We have at least 2 patients with hypospadias. Renal anomalies, I don't see this, but we do have some concerns about hydronephrosis, contracted kidneys, and cysts. Unfortunately, we work with a wonderful nephrologist, Alana Paul. So an evaluation by the gynecologist, didn't have time. Macromastia is a feature that I am interested in. Macromastia means large breasts, usually earlier onset. Sometimes I will just ask, what is your bra size, and compare it to their stature. So this is seen in 18%. And there is at least one person who attempted pregnancy, was in an IVF program, was not successful in getting pregnant, and then we certainly have no live births in our series. So what about appearance? It varies with time and ethnic group, mood, attitude, glasses, hair, setting, pose, all those things when you take a picture. And with any syndrome, children look more like each other as toddlers, but especially in Myhre syndrome, than their family members. And with age, like people in general, the face lengthens, the nose lengthens, the chin gets a little more prominent. And these are 2 wonderful montages contributed by their parents, and I thank you. And here's one young boy. I think you can see this is what we call the young face of Myhre syndrome, for lack of a better example. And over time, like any person, the face does change a little bit. Here is another little girl. And again, the similarity between unrelated children. So Myhre syndrome around the world, I've done a systematic montage of all the different countries that I could find. And this is not for detailed review. You can do this on your own time, but you can see such similarities. But then you see people who look more different, okay? And you have to wonder, is there anything different about them, or is it their growth? And I don't have those answers. But does it depend on the type of variant, isoleucine 500 or the arginine 496? Does it matter? Maybe. If so, is this a clue? Is this a signal for the rest of the body? Does it provide insight into prognosis if we can see a change over time? Does it predict what else we need to look for? I just say these things because we need to be sure that parents understand we're not doing this out of curiosity. There's usually a hypothesis that is driving the search, although we may not always voice it. So can we answer the question now? I need more people, different ages, different backgrounds, but I show you a very valuable montage, and all of the parents gave explicit permission for me to use this. If they did not, you'll see just a colored circle. So 28 out of 40, 70% gave me permission. The ones that I blurred photogenically were families that were not completely comfortable, and I will do whatever the families want. So I first want you just to look at children between 3 to 12 with the arginine 496 variant. Just look, okay? The ones that have a black square, I've highlighted people who have a non-white background. The ones that have a dashed are multi-ethnic biracial. Let's just look at the different faces. Some of you may recognize your children. And now I'm going to compare this to the other variant, the isoleucine 501. And again, look at the youngest children coming down and the adults. You could compare from side to side. You can compare the adults. So I have not done formal morphometrics, cephalometrics, anything like that. And my colleagues know that that's what you need to do to really discern differences. But when I've shown this to people time and time again, nobody has been able to say, we can see a difference. So what does one family tell us? And I will make this very brief because Bert did such a nice job in his talk. This remarkable family reported by Ilse Myhre with the first report of familial Myhre syndrome, a mother, her two children. And at the time of this report, the other program was not known to have affected family members, but he does too. So you might say, well, we can see the children have a very mild, but this is sort of the Myhre look. The mother is older. These are not really great pictures, but the profile is clearly a Myhre profile. This is called midfacial hypoplasia. This is prognathism. The ears are low set. They're a little bit unusual. So what about artificial intelligence? What about what is happening in genetics and dysmorphology? So this is the company called Phase 2 DNA. Everybody's welcome to go and check out their wonderful website. And this sample patient, by the way, does not have Myhre syndrome. She's just illustrative. But here is the composite that you've heard about. This is the face that they compiled. They based it on some new patients. They based it on the literature. And when I first saw it, I was stunned. I thought this reminded me exactly of some of my patients. And you can see these are the narrower eyes. They're more deeply set, a more prominent nose. It's not a big nose. It's just more prominent. The small mouth, the thin upper lip. And I know of one patient in my group that was clearly diagnosed simultaneously as they were waiting for the gene. The excellent dysmorphologist used this and say, I think this is Myhre syndrome. I know of another patient out there who's coming. So in terms of immunity, there is a pre-recorded talk by Dr. Pam Guerrero from the NIH. I think we are blessed to have her collaboration. Here is an NIH researcher with a fully funded, well-structured, detailed evaluation of immunity. You don't want to do what we do sometimes, which is just to say, well, let's get quantitative immunoglobulins. That is too superficial. This is like taking the plunge when you manage your patients with DiGeorge syndrome. You have to do it all. I can say that at least 3, maybe 6 patients have enrolled. We have seen some low IgG. One patient has been treated with infusions, one patient elevated, one low. This is too small upon which to base therapy. And I haven't listened to her talk yet. I can't wait to do that later today. So cancer is something that is an interest. They allowed me to record a special talk, and I will have to ask you to listen to that because it's very detailed. I don't want to give it just a quick survey. So this is my summary. The original features described by Dr. Myhre in 1981 are present in most of the people, but the spectrum is greater. So the 2 individuals, they were males with striking short stature, probably clear intellectual disability, does not predict your child. But the features, the notion of statural is common, short stature, the notion of an impact on development is still real. The spectrum is huge. And this is a delightful patient at her high school graduation. She takes AP courses and she will be going to some type of a college in the future. So the ongoing research of natural history is essential, underway. Thank you to Team Ghent and other people. Sophia, by the way, Nicola, myself. Progression of features can occur. It's hard for me to say this. It's hard for parents to see this, but that is a reality. And the features are both congenital developmental versus acquired. Mark will expand on that. There are novel features are still valuable. In genetics, we always wonder, is it worth reporting one patient? So this single patient that we first learned about with tetralogy of Fallot became a second, and now we have, I think, seven. But research is needed to advance from just case reports to series to insights, say, about neural crest. And though delays are ubiquitous, cognitive ability, behavioral issues, autism, speech delays can vary and can improve. Okay. I don't know anybody who does not speak ever. It's just extremely delayed. And many people with Myhre syndrome have insight into their own past. They're able to reflect on their younger selves. And at the same time, many families are challenged daily. It's a severe phenotype. So this is, I think, the fun part. Where should we go? So we need to advance from clinical description of individual defects to phenotype problem solving and pathophysiologic paradigms. So that's a lot of words for this. Congenital versus acquired. Thinking about the aorta as a cluster, aorta, hypertension, renal function. So Mark and I have the pleasure of talking to our nephrologist and the imaging people more broadly about what's going on. The proliferative response in skin, joints, ears, airway. Is there a cluster? Does one predict the others? If you have 2 out of the 3 or 4 or 5, does this mean you will probably get the most severe problem, which is the arthritis, the arthropathy? What about puberty, premature puberty or early menopause, uterine hyperplasia that I think is responsible for neoplasia? Does this mean that we should be imaging more, doing some biopsy? I do think we need some tissue. And this notion of spinal cord and vertebral anomalies, both caudal in the neck, cranial in the neck, caudal in the lower spine, neurogenic bowel and bladder. Put it all together as a cluster, not just one defect. What about surgery, instrumentations, and airway protection? As I said, I do think that the concern about the airway is probably more related to sort of an idiosyncratic response to proliferation. I don't think it is a direct response to airway trauma, but I think there's always going to be the first patient, and we don't want that to happen, so we're very cautious. At MGH, I've been having what I call my mini conferences. I had a conference to talk about arthritis with MGH, Mayo Clinic, and Hopkins, constipation, calling on people, the eyes, the papilledema. But of course, we need at the same time to be funding and developing animal models. It takes funds to do these very expensive but critical studies. Therapy, of course, is our dream, isn't it? To advance from systematic to genetic-based therapies. As a rare syndrome, the role of smaller trials may be valid because the idea of a randomized control study is not going to happen for a rare syndrome like Myhre syndrome. So at MGH, we're developing the REDCap database that will allow us to perform multivariable analyses, do the genotype phenotype analyses, do a better job of looking at demographics. And the international Myhre syndrome community is just such a pleasure to work with. So I call them Team Ghent, have taken the lead for the study of the adults. The Neural Crest is being led by Team Naples. So we are an international group. And the registry, I know this is a resource. I personally think that it is most useful for attitudes. I think that parents will confide to a registry more than they might tell us in clinic. Descriptive epidemiology to tell us who has Myhre syndrome where at what ages. Outside collaborators, I thank Dr. Pam Guerrero at the NIH. For epidemiology prevalence, it will have to be a collaboration. I think Bert has done a great first effort. And I want to talk a little bit about genetics, not only this, but the idea of epigenetics. I'm asked all the time if I think that the different variants will separate out the differences. I think I know enough now to say that yes, for growth, there seems to be a change. Number two, just this weekend, I've learned there might be a difference with the isoleucine 500 to methionine variant, possibly might be related to something with longer function, better function in adults. So that's something we'll have to work out. But epigenetics is sort of a buzzword, as my colleagues know, in many parts of medicine. And I think that this is going to play a role in Myhre syndrome. We have a collaborator in Canada who we are going to work with. I'd like people to help me explore the advanced paternal or maybe parental age. The advanced parental age might be just sort of a socio-cultural trend. Twinning. Twinning is, I think, a clue. It may be related to the age of the parents or how patients get, the age of the parents, but it also might be related to epigenetics. And I do need to make a pitch to all of us. I think about this all the time. We need tissue. We need not only the tissue that um, animals can give us, but our own patients. But it takes an effort. It takes a research study that allows you to collect blood and bank it. When possible, skin. And I congratulate my colleagues, Bert, Nicola, who have looked at the skin in the research studies. Congratulations, it has been done. But we just need to do more. And other tissues. If people do a colonoscopy, if a biopsy is taken, then we need to have some of those tissues too. And so I want to acknowledge the Myhre syndrome families and their networks who are making events like this and future research possible. This may be the first, but I hope it's an annual event. And the Myhre syndrome clinic team that I work with at MGH, wonderful, generous colleagues, you can't imagine. The professional advisory board. Whoops, my animation got a little out of whack, sorry. My clinic team at MGH also includes two research assistants, Greg Giwala and Eleanor. I have to thank Fund Development, who helps me raise the funding for what I pay for, which is our mouse work as well as the research assistant, and thank the foundation also. Referring physicians, too numerous to count, and some other colleagues at MGH. And so I leave you with this site of the famous set of statues called Make Way for Ducklings, and Myhre syndrome, as one of our patients shows us. And thank you for listening. I have included some references on this at the end of this talk for people who are viewing this. On the left side are those that are probably more family friendly and include the Myhre Syndrome Foundation website. And these are just a sample, a mere sample of the world's literature, but I divided it into the earliest reports, gene discovery, key reviews, case series, case reports. If I'm missing anything, I apologize. These are extra slides, but I'm not going to show them. So thank you, everybody, and I will stop now.
Thank you, Dr. Lynn. That was fantastic. Great information. We did have one question from a physician. Are you open to taking a question?
Oh, very much so.
We see increased risk of congenital heart disease in twins, especially in those using assisted reproductive technology. I wonder if twin IVF could increase risk of Myhre as well as other single gene defects.
So I've been part of some studies in my role in public health birth defect surveillance, looking at IVF, ART, and defects. I don't think the data is crystal clear. So first of all, I hesitate to make any comment about the risk association of IVF and defects. So I'm talking about defects. There is an association, I think, that's been well established with a few syndromes, Beckwith-Wiedemann, and I respect those. Kathy, read me the rest of the question, please.
That was the question. We see increased risk of congenital heart defects in twins, especially in those using assisted reproductive technology. I wonder if twin IVF could increase risk of Myhre as well as other single gene defects.
So thank you for phrasing. So again, my first thing was to say that I don't think the association of IVF, ART, and CHDs is robust. I think it may have been popped up, and I'm not sure it's that strong. So I have to start with that. Now, what about the role of possible IVF and twinning in Myhre syndrome? Definitely fertile ground. I think I skimmed by the fact that some of my patients had undergone IVF, but as far as I know, and I will go back and check, none of my patients who had twins had the twinning through IVF, and I have to go back and check. But I did note that some of the patients had undergone that, but for a variety of reasons. There was advanced parental age, sperm dysfunction, etc. So whoever my colleague is who asked that question, feel free to contact me. We can talk more. Other questions?
That was it.
Okay.
Thank you so much.
There's one more question.
Go ahead. Okay. The one here. Okay. Yes. I'm sorry. The question is, I don't know much about CRISPR, but is this at all a possible future treatment of Myhre syndrome?
So everybody knows about CRISPR, right? You get the best information from reading the New York Times and the Wall Street Journal. And CRISPR would seem to be just the ultimate, wouldn't it? It's not low-hanging fruit, though, at all. Could it be a dream? Sure. CRISPR was used, this is my opinion as a clinical geneticist, was used initially for autosomal recessive diseases in which there was a progression. But if you're going to use CRISPR, you have to decide when will it be most useful. So number 2, Myhre is a single gene disorder, and there is some interest in using it for that. But when would you use it and what would you change? Oh, by the way, Mark is going to be discussing CRISPR, so I'm actually going to stop. So I've just sort of given you a teaser for his talk.